back in August of 2013, the cover story for CardioSource World News questioned 30-day readmission as a possibly lousy quality metric in heart failure. Given the 5.7 million and counting Americans with heart failure, it's really an important issue. And so the JACC Heart Failure has a paper based on a presentation here in New Orleans at AHA 16, and the paper is Association of 30-Day Readmission Metric for Heart Failure under the Hospital Readmissions Reduction Program with Quality of Care and Outcomes. And to talk about this, I'm with Dr. Ambarish Pandey, who is an MD and a third-year clinical fellow at the University of Texas Southwestern Medical Center. Now, obviously, 3 years ago, we were already debating the 30-day readmission metric and questioning it. Remind us of the issues that are at the heart of this debate.
I think the major issue is of inequity in the penalty amount that is imposed on different hospitals, and we see that centers who may be serving the socioeconomically more challenged population of heart failure patients, they are facing the same amount of penalty as some higher well-funded centers which have more resources. And what we see in our study is that the readmission rates and associated penalties are not actually associated with any long-term clinical outcomes or even quality of care. So you see this injustice, or if I may say, in the implementation of these penalties, where centers who may not actually be providing bad care or even have bad outcomes for in the long run, but are actually facing more penalties. And we also see the penalties are more to centers who serve more of the economically challenged or more of the ethnically, centers with more African American patients are getting more penalties. So I think that is the main core issue here.
I mean, in an accompanying editorial comment to your paper, Marvin Konstam, MD, he actually noted that of the 6 diagnoses now that can lead to a readmission penalty, they are overall expected to exact more than $500 million in withheld Medicare reimbursement from more than half of the nation's hospitals. So those are the numbers. That's huge.
That's staggering. Yeah, the impact of these penalties has been huge in terms of limiting the resources that hospitals have to spend on other meaningful quality outcomes, and this is a challenge. The first major question is whether or not 30-day readmissions actually mean anything. They may mean something in terms of financial outcomes, such that penalties may help hospitals reduce their cost of care in the long run. But from clinical outcome standpoint and from quality of care standpoint, what we see in our study is that it does not really differentiate hospitals based on the quality of care they provide or the kind of outcome they have in the long run.
So how did you conduct the study? And this is being published in JACC Heart Failure.
Right, so this was an interesting study design. We used the Get With the Guideline Heart Failure database, and we identified the centers that had participated in the first cycle of the hospital readmission reduction program, and we looked at the heart failure patients at those centers who were admitted between 2009 to 2012. And this time period was chosen because this is the same time period which was used for the first cycle of penalty. And then we looked at their quality of care, which is captured in a very good way in the Get With the Guideline registry. And then we looked at their one-year outcomes using the CMS Link database. And then we compared their outcomes within centers who had a lower than expected readmission and then higher than expected readmission. And we see no difference in their outcomes or their quality of care.
So while the government has certainly saved precious healthcare dollars, the question has remained, have patients benefited? And what you found is
not really. Yeah.
Not really. So you note some important limitations to your study. Let's mention those first.
Right. So there, like any observational data, there are some limitations to our study as well. Number one being we are only limited to the Get With the Guidelines heart failure participating centers. So what we don't know is whether these findings are applicable to centers that do not participate in the Get With the Guideline Heart Failure program. And it is important because the centers participating in the Get With the Guideline program may actually have higher quality of care from being in the program itself, and that may limit our ability to tease out small differences in the quality of care across hospitals. And also, we have not looked at the impact of implementation on long-term follow-up, which is something that needs to be studied further, whether or not implementation of these penalties have led to an improvement in outcome in terms of readmission or mortality on further downstream follow-up. I think these two are major limitations that we need to address and we need to evaluate in future studies.
I mean, Dr. Konstam noted that there's been a report of inverse correlation across hospitals between rates of 30-day readmission and mortality. Yeah. And he said this is likely linked to the fact that patients who die cannot be hospitalized. Yeah. So it's difficult to rationalize why CMS policymakers choose to omit death from their metric.
Exactly. And that's our point too, that you have to adjust for death or risk of mortality when you calculate your risk of 30-day readmission, and it has been previously shown that 30-day readmission is inversely associated with 30-day mortality, but ours is the first study that looked at 30-day readmission and long-term mortality with 1-year data, and we show that the inverse association is maintained even at long-term follow-up. And I think this is something that CMS has to take heed of and then adjust for the competing risk of mortality when calculating the performance metric based on readmission.
So what can we learn from this? What's the take-home message?
I think the take-home message is that focusing too much on readmission may be actually not the best way to go forward. If the goal is to improve quality of care and clinical outcomes in patients, it may work for financial incentives and reducing heart failure cost of care, but I think if we have to address the larger issue of clinical outcomes, we need to take into account other issues like the differences in the actual the nature of population that is being served at different hospitals, and then we need to come up with better metrics which may be more sensitive to the care quality provided and may better capture the long-term clinical outcome differences, and then use them to like penalize or reward centers for the.
Right. Well, the paper by Dr. Pandey and colleagues, please check that in JACC Heart Failure, data presented here at AHA 2016. I'm Rick McGuire.